There's someone else waiting in the lobby, and um, okay, they're admitting right now.
Yeah, I think I may need to change the settings to allow everyone to bypass the lobby. Yeah, here we go.
Hey, Michelle, on mine it says there's a. Oh, never mind. It's all good now. Okay, well, I'm going to go ahead and get started with the disclaimer. Hello, everybody. My name is Kelly Sandacre. I'm the SUDISA administrator. For this, I'm also the SUDISA administrator and Safe Supply administrator. And so I'll be starting off with our disclaimer slides. Um, just disclaimer, this meeting is being recorded and will be posted to the HCA website on a webpage dedicated to SUDISA work group. Please begin recording. I believe Michelle's already started recording. This recording is open to public disclosure. Please do not disclose any private or confidential information. Guidelines for public feedback. This work group is not subject to the Open Public Meeting Act. Members of the public are welcome to attend and observe the SUD Intake Screening and Assessment SUDISA work group meetings. Meetings are participation, including the use of the chat, will be limited to work group members unless otherwise specified, i.e., guest participants, panelists, presenters, etc. If you are not a committee member and would like to provide comment or questions for the work group consideration, please email HCA ESB 5476
Hi, this is
at.
Sue at Lakeside Milam.
Oh, hey, Sue, we can hear you. I'm going to mute you. I'm going to go ahead and repeat the last one. If you're not a committee member and would like to provide comment or questions for the work group consideration, please email HCA ESB 5476 at hca.wa.gov. And the work group administrator will share your message with the work group. Okay, that is it for that. All right. Next. Oh, that's not what's supposed to be next. And so, just so everybody knows, I always share the SharePoint page. This is how we keep in constant contact. I see quite a few of you actually were in it here this past week, going to the to our recommendations and such. Oh, sharing about associations next. All right, so I'm just go down the list here of associations. If there's anybody here in these associations, and I just have the email's been sent, but I don't have a response. If you want to drop in the chat the email for that association, maybe I didn't do the right email or something, and I can go ahead and email that association and still get a response. We still got some time. So as of right now, the WADCP, I have a presentation on August 15th. Um, Washington State Hospital Association has chosen option 3. When you guys see option 3, that means they've chosen the email option. We gave the associations 3 different options. One where HCA can present to them, one where they can come to SUDISA, and one where we can send them an email and they can make what recommendations they want in an email and then send it back to us. And so if you see option 3, that's what it means. AAP, I'm presenting on August 16th. WAADAC email was sent. Designated Crisis Response Association email was sent. SUD College Educators email was sent. AWHP, they're going to go with option 3 as well. OIC is option 3 as well. Office of Travel Affairs, I'll be presenting to Office of Travel Affairs on August 14th. Washington State, so the ones in red, you guys here, I'm not going to read them off. The ones in red right now, I haven't received a response. It doesn't mean they're not going to respond. They just might not check their emails as regularly, and so we'll wait and see. But again, if you're someone from one of these associations that are in red, just let me know, and and if there's another email I can use, I'll go ahead and email that association. Office of Behavioral Health and Advocacy, option 3. Washington Council for Behavioral Health, option 3. And Washington State Association for Treatment of Opiate Dependency, and they've chosen option 3. And so some associations chose option 3 mostly because when they're meeting, we have to have the recommendation done way before when they're going to meet next. And so an email was just a little bit quicker for them. Next on the list, I did want to share a tidbit of information because I think it would be really great. We've talked about this a couple times in the group, and I'm just going to drop it in the chat for you guys. So we've talked quite a bit about this, and it looks like there's somebody going to actually even start working on it, which is kind of cool. But as you guys know, elderly people who are on Medicare right now, there's only like one treatment facility inpatient they can go to right now. It's really like, where can they go? And right now, there's an act started from U.S. Senator Bob Casey. I believe that's Pennsylvania. He's the chairman of the U.S. Senate Specials Committee on Aging, and he's going to be introducing the Residential Recovery for Seniors Act. And so, if you guys want to go ahead and look into that a little bit more, I looked into it. It popped up in my news feed, and I thought it'd be really interesting for everybody. But basically, what it is that they want to make it where Medicare would pay for residential treatment of care. It doesn't talk about the specifics of how that would work or where the money would come from or how much their bed rates would be or anything like that. It just says that they want to go ahead and try to see if they can make it happen. So I thought I'd just let you guys know about it because it's pretty interesting. Okay, next on the agenda. So I don't mind sharing the agenda with everybody because everybody's already seen it. So on our agenda, we have for the next hour and 10 minutes. Oh, I have it all. I just noticed this. I have the agenda. It says it starts at 1:05, and I have the start times at 9:05 to 10:25. Okay, that's supposed to be 1:05 for everybody. So 1:15. We're making good time. We're at 1:12. So we're going to be going over each of the recommendations. And I know I've been talking a lot in the beginning of this, but I will pause here once we go to the first recommendation so I can hear some feedback from everybody, and I'll be reading over. This is closed. Real quick, out of the associations that I mentioned, was there anybody that saw anything from any of the associations that you're a part of, or anything like that, that maybe I don't have the correct email, or I should have a quicker response from somebody? Okay. Um, Again, if for some reason you saw an association that you're a part of, and I need to do a different email, just go ahead and drop it in the chat, and I'll go ahead and make note of it. All right, everybody. So this is our first recommendation. Increase the Medicaid fee schedule reimbursement rates for behavioral health services so that behavioral health services providers, facilities, and organizations providing substance use disorder. Oh, I see some people are going in. Substance use disorder treatment can offer higher wages to substance use treatment providers. This was added after the fact. Use the comparison rate study to inform targeted Medicaid rate increase on both managed care and fee for service for SUD providers for areas that are under resourced, and increase rate for room and board. So what that means was, is Teresa on the call? No, I don't think she is. Oh, wait, maybe she might be. No, she's not. That's okay. Me and her went over this. I'm the one who typed it in, so she explained it to me. I think if there's anybody else on the call from HCA, that correct me if I'm wrong about this, but there's a comparison rate study that happens that compares how much the better rate should be and how much certain SUD services should be, like how much we should be charging. And what should happen is that this comparison rate study will show how much of an increase Washington State should have. And so basically, this this recommendation includes that comparison rate study. Because I talked to Physical over with HCA, and when they saw this, they were like, "Well, what do you want to increase?" I told them everything, and that wasn't like really that's not the way they go with that. So I was like, okay, I understand. So using this as a more evidence based, I guess you could say, on a way to help increase the rates. Uh, yeah, I think, and I will correct that. Medicaid. All right, so there's been research done by many people. I'm gonna go start off with reading the comments and stuff, and then if you have something, I see something for people. Oh, I see a hand raised. Okay, Dominique.
I'm not sure if this aligns with this particular one, but it struck me because when we're talking about payment, something that could be helpful is for there to be incentive for other agencies to accept assessments from other agencies versus um, doing them themselves. I
What do
don't
you
know
mean
if that
by
makes
it's?
sense.
I mean,
So
it
if a
kind of
patient
makes.
has an assessment from somewhere,
Mm-hmm.
an agency, is there a way to give them a financial incentive to accept the assessment from another agency so that the patient can get into treatment sooner?
Can you drop that question down in the chat for me, Dominique? And I'm going to add it to the end of this recommendation. I'm going to put a comment on it, and then I'll try to get with somebody from physical or anywhere else in the world where to see if that's a possibility.
And Dominique, this is Sarah from Healthcare Authority. I would just want to clarify that question to make sure we're framing it correctly. Is that to accept assessments for inpatient treatment?
It could be inpatient, it could be OP, it could be IOP, where because someone can receive an assessment from somewhere that quantifies them for IOP, and like at an ER where there's nothing open, there's nowhere for them to get into, and then when they find a place that has a bed, they have to wait, they get put on the list for another assessment when they've already got an assessment that could get them into treatment.
Okay, thank you.
Yeah, and so Dominic, when you put that question in there, go ahead and mention all levels of care, so then that I know when I'm asking the question to physical or whoever, Medicaid side or anything, to see if there's any way, is there any incentive-based way of doing it? Because I can add that to this, and I can set up a meeting with someone in the HCA and see if that's possible. If it's not possible, I'll email you back and let you know. I just don't, yeah, I just don't know the answer to that, but that's some ingenuity there, though. And as thank you, Dominique, for raising your hand. If any of you have anything to say during the recommendation, just go ahead and raise your hand. I'm going to pop over and look. Every so often, I see the raised hand. You can also utilize the chat. I'm looking at that as well. Um, so something for the comments. So Amy Sawyer. Amy, are you on the chat? Are you on the meeting right now? Okay. No, Amy today, but she did email me this. And so she looked into it, and basically, if any of you want to go ahead and read the comment, it's kind of long and it has some researchable sites and everything like that. Is for bed and room rate right now, we're actually one of the highest in the nation. We're at $14 an hour, and I guess the average is 7 to 10. Um, I was kind of surprised to hear that. I thought that we'd be lower, to tell you the truth. Um, and then she put her statistics right here. Um, And then Brandy, Brandy, are you on the call right now? I think you might be on vacation or PTO or something. I last saw coming back tomorrow, I think. Brandy had put, I agree, but between this and the recent rate study, I find it difficult to develop fine and supporting information for this recommendation. I believe other initiatives with SUDP applications, continuing renewal costs may increase the workforce hiring. So I will say with the renewal starting in July, I believe it started in July, SUDPs and SUDPT, everything just, well, SUDPT was already $100, but SUDP is already $100 for renewal. It went down to that. And that stays in effect forever long the law said that it was stays in effect. I forgot the year that it ends. Brandy makes a good point. Many SUDPTs spend a lot of money and time on CEs, maintain licensure. Many SUD agencies cannot afford to pay for staff CEs and or CE time. Could the state help provide enough free? Uh, I don't know that word. Or maybe it's two words together.
I think
Applicable.
it's asynchronous, so meaning yeah, that you don't need to attend live, but could receive some of the trainings like where you take them as a self-paced online training.
Okay. Thank you for the clarification, Sarah. I'm gonna be honest with you guys. I didn't know what that word meant, so I'm glad Sarah told me. Asynchronous applicability SUD CE training, so that SUPs we're not spending so much money on CEs at each year. Um, I believe, and if I'm wrong about this, someone from HCA correct me on this, but I believe like King County, for example, does CEUs, and that comes from, and I don't believe that if you're an SUDP and you're in King County, you have to pay for SUDP CEUs because it's paid for through one of the taxes in King County. And so I think that's kind of what Molly might be talking about, is something like that. So Couple other comments. Nature of low rate wages. If we don't have staff, we can't serve people. How could it be tracked to ensure that if fee schedule changed, these funds were used to recruitment, retention, and development of SUD staff? Someone asked where this data was coming from right here. I think we ended up, I haven't accepted it because I didn't know who put the cross out mark on it. So basically this is the whole recommendation. I hope some of you have had some time with it. I am here now to be a little bit more of a listener and kind of hear from you all if there's anything that I need to add right now. If there's anything you want to add to this, you can just raise your hand or chat or put it chat. Okay, so I see the comment from Dominique. I'm gonna go ahead and add that into right here. All right. I'm gonna put this down as an asterisk. And I have to go off camera just for a second. Sorry about that, folks. I am back now. I'm looking for that asterisk. I'll make sure that I ask the question to who I need to. Is there anything else? What about government agencies? Would they be eligible for those initiatives? Oh, okay, I can put that also in the yellow. Okay. And then I got all right, Wayne.
Sorry. Actually, I'm off on the thing in the chat about the financial assessment or financial incentive for assessments. And what's concerning about that to me is you're putting a client through 2 assessments unnecessarily to bill for a second assessment. It seems to me that shouldn't be an issue of financial assessment. It should be somehow that should be not allowed as a process. It seems frankly unethical.
No, the question is to provide incentives so the patient doesn't have to wait for an additional assessment if they get an assessment somewhere else.
Yeah, why would they have to wait for an additional assessment? That's what I'm concerned about.
Because agencies have waiting lists for assessments.
But when you say additional, I'm assuming there's already one.
A patient can receive an assessment in an ER.
Yeah.
That does not belong to a facility. That patient can take that assessment to another facility and they will not accept it.
That's the problem, though. Why won't they accept it?
And that's because everybody's got their reasons. Part of it is because people wanted to charge for the assessment.
And that's the part I'm saying that seems unethical to me, because it's putting a client through an unnecessary hurdle of this is exactly about assessment and intake, and now we're forcing someone to go through 2 assessments just because we want to bill for that. That's very concerning.
And that's the issue. That's the historical problem.
Yeah, I haven't encountered that. I'm on the other end of receiving assessments. We don't do that here, but that seems like it wouldn't be, it's really an ethical issue, because or MCO shouldn't pay for 2 assessments within that time window unless there's a demonstrated need for those or something. Yeah. All right, thank you for clarification.
I can also, with other HCA folks, I can also explore the ethical concern right here, and along with the initiative on top of it, and the MCO concern as well. Is there anything that anybody wants to bring up about recommendation 1? Okay. We can go back to this if for some reason something pops in your mind. These are the recommendations are it should, I don't know. I'll pop it. Oh, there we go. The recommendations are on SharePoint. All of you should have access to the SharePoint and such. So I'll go ahead and make sure to put it on there. If you guys want to go ahead and I'm going to put track changer back on. I took it off while we were reviewing it together. There we go. Now we're going to be tracking changes. You can also do what other folks have done, which is you can put comments right here and you can add your comments. You can also respond to the comments as well. So if there's something you want to do, you can do it there. All right. I see a couple of you went ahead and clicked on the link. Very cool. All right. So if you want to, I'm going to go ahead and move on to recommendation 2. Just last a little bit. Is there anybody else that wants to raise their hand for recommendation 1? Okay. Move on to the next recommendation. All right. Recommendation 2 was education campaign to clarify state requirements related to intake and assessments that must be administered prior to providing different types of behavioral health services. So some of these was, and we don't necessarily have to do all the education campaigns on this, but this is what was discussed during our time on the mural and such. And all of you have access to this. So I'm going to go ahead and copy and paste.
Hey, Kelly, really quick. I
Yeah.
saw there was in the chat a question about the first recommendation.
Yeah, I added it.
Oh,
I
that
added it
Sharni
right here.
Chris added. Oh, thank you. Sorry about that. I missed it.
Yep. No, thank you, Sarah, for pointing that out. Yeah, I added it right here on the thing, and I put it all in yellow so I could remember. For recommendation 2, this is about educational campaigns. So first one is, I'm not going to read all this. I'm going to summarize it. So education about removal of X waiver. So this would be an education campaign towards mostly providers, because right now there are providers in the state that don't know the X waiver has been removed. They'll still say they can't prescribe because the X waiver, and an educational campaign would be to make sure that every provider in the state knows that okay. Education about removal of X waiver, and so that's what that primarily is surrounding. Education on inpatient, no wrong door. As some of you guys know who work in inpatients, and some of you that do assessments and send people to inpatient, no wrong door got rid of prior authorizations. But one of the big things it also did, it got rid of the fact that like you don't necessarily need a full assessment completed to accept someone into inpatient treatment. You can do that with a screening to see if they're acceptable for your inpatient, and they can get the assessment done when they get in. That's because both levels of care, residential and withdrawal management, which Brandy, by the way, thank you for correcting the spelling in here that says we put detox in there and you correct it with withdrawal management. Thank you. So no wrong door, you get a certain amount of days paid for this. And so that gives you time to do the assessment. And so this would be a educational campaign at inpatient treatment centers talking about processes and processes to get people in the door quicker and what's the fastest way and stuff, right? Educational campaign on social workers. Understand that they can do SUD assessments if within scope. So remember, there was a waiver done. I believe it was a waiver. I should have put a link here for it. Oh, I think I did right here. It's in the state. It's in the state plan, section 13D. That, and I just mentioned LMCHs, LMCHSAs, licensed social workers. Those are just the ones I put, but there's like 13 credentials actually for this, for right here, social worker. There's like 13 of them. So they can do it if they're at a behavioral health agency. They've been trained and it's within their scope to do it. And right now, not a lot of people at behavioral health agencies even know that. They can do it right now. They can do an SUD assessment, and they just need to go to training, and they need to get the training and stuff. So, I mean, this will be really great educational campaign. Educational campaign on Scalia Northwest. As you guys know, they actually presented to us, and I think that Scalia Northwest could actually use additional funding. So this would be for them to get funding so they could go out even more to more ERs and just a brief little thing about Scholarly Northwest. This was the presenter we had, Liz. They talked about, I can actually go to the website just real quick so we can look at it. So if a patient arrives to the ER and a doctor is not sure about, should I prescribe someone Suboxone or something? I'm just not sure. I feel very hesitant about it. They can go to 4 clinicians and they can go to start treatment, and this will provide everything that a doctor needs to know. But also the same thing is that Scholarly Northwest, if someone needs follow-up, they can call the main line, and the hospital has to be part of this. So you have to be contracted for this. So just because you see the website here, you have to be in contact with our person over HCA, and you have to be a part of this network. And so that's where the educational campaign comes in. But basically, if a patient wants to get care and then have follow-up, they call that number and they're set up with an agency that does medically assisted treatment right after you get done with the ER appointment, And so they presented to us, and a lot of people really like their presentation. And so that's something that was spoken about doing an educational campaign. Educational campaign on CJTA fundings for peer services to conduct outreach for court-involved individuals. Right now, there is funding in each of the counties for people who are court-involved to get peer services. However, the funding is basically being kind of underutilized. Hey, Sarah, I know I didn't talk to you beforehand, but do you think you could share a little bit about CJTA funding?
Oh, sure. So the Criminal Justice Treatment Account is appropriations that the Healthcare Authority Division of Behavioral Health and Recovery gets from the state treasury to provide to local counties and their jurisdictional courts. So they can opt as a county to dispense their allocated funds themselves, or to have the local BHASO, Behavioral Health Administrative Service Organization, dispense those funds. And they're used to support any recovery related activities for people who are like clients in those local courts or therapeutic courts. And then there's sort of another subsect of those funds that are specifically to help stand up treatment courts or therapeutic courts within communities. And so CJTA is like a funder of last resort. So if Medicaid can cover a service, for example, for someone who's Medicaid insured, of course, we would want to leverage those Medicaid funds, but CJTA can provide funding for some of those like non-Medicaid covered services, or for people who are uninsured or underinsured to support in their recovery. And there is a lot of counties are using some of those funds to this point to support peer outreach for individuals who are court involved, to help get them connected to the supports they need. So, this wouldn't be, of course, funding that would be applicable or available to anyone, but maybe a smaller subsect of people who are to support and peer outreach for folks who are court involved.
Thanks, Sarah. Appreciate that. Okay. All right. So I have put the link in there. Is there anything that somebody would like to talk about with recommendation 2? Something to take out, take away. All right. David?
Yeah, I had put the comment, and this is also for clarification on, or can we make a recommendation? I feel like a bigger barrier in a lot of settings is getting assessments at alternative locations rather than a licensed behavioral health agency like medical clinics and ERs. So I don't know what that recommendation would look like. But an example is I'm in a primary care clinic. I have a master's level social worker. I'm a board certified addiction medicine physician, and like we can't do an assessment that Medicaid would accept right now, which and we know our patients really well, right? So we could do it pretty quickly. We know their long-term history. We know a lot of the information without even having to ask the question again. So to me, that's a big barrier, because I think there are a lot of medical clinics with social workers on staff who could be trained and could do these assessments. But I don't know if that's what would need to change for that.
No, but what I'm going to do is mark it here as a note. I'm highlighting it. And so basically non-BHAs, which is like so a non-behavioral health agency credential staff to be able to conduct an SUD assessment, basically. And so I'm going to look further into that, and then I can get back to you, David. I see your comment right here, so I put it right underneath that one where you put that.
Thank you.
Yeah. You know, I feel like I wish Eliza was here to tell you the truth. I feel like there's something. If there, I'm glad you notated it, David. I believe there's something going on with non-BHAs where credential staff can do an assessment, but I don't want to really say there is without her here. I'm gonna reach out to her. I think she gets back tomorrow. And if the answer is here, I might tag you in this so that you see that the answer has been answered if there is something that does that. Thank you so much, David. Any other comments or recommendation too? I'm gonna close this out. All right, if that changes, you still have, I'm going to turn tracking on now. And so if that changes and anybody wants to put comments here, or if you want to track your changes here, then that's turned on right now and it'll track it that way. All right. Recommendation 3, which is, man, I know I didn't talk to you beforehand, but I might ask you to speak about SIRSAC, about the one member who was made a certain request, and so this might be a big topic of conversation here in a second. But expand peer service specific services, peer specific services that can be provided prior to completion of assessment / intake. Expand BH care coordination and community reintegration to include other settings, emergency department, homeless encampments. And so the heart of this recommendation, what's been discussed and everything for this is that to make it so that peers can bill Medicaid prior to an SUD assessment or diagnosis. Right now, peers can only bill when there's a crisis. They cannot bill prior to that. They need to have. And so if someone's like, well, yeah, I'll come for the assessment on Tuesday, but I don't know how long I don't know if I'm really going to make it. They can't be technically engaged with a peer for reimbursement purposes. So this would help expand that. Meta, do you think maybe you'd want to share on what was shared at what someone's concern was that's who's a peer?
Yeah, so one of the SIRSAC members really got kind of caught up on this and had a whole bunch of feedback to give. So we ended up meeting separately to make sure that we captured that feedback. I think my takeaway was that if we're looking at, so we want to be able to, as a provider, want to be able to provide peer services prior to an assessment being completed, because I think we know that can make a difference for people in terms of their ability to follow through with an assessment and engage fully with services, right? So the question is how to make that sustainable in terms of funding, because a lot of the programs that are successful with that right now are grant-funded programs. So one of the options is making it Medicaid billable. Now the SIRSAC member's concern was that if it's Medicaid billable, then that adds an extra layer of credentialing for the peer. It adds, potentially extra barriers for folks participating in terms of being able to, you have to collect certain information in order to bill Medicaid. And some of the successful outreach programs don't necessarily do that until later on in the process, depending on how difficult the rapport building process is with somebody. So that any of those engagements early on, when there wasn't complete information, might not be billable. If the person did not have, if the peer did not have the right type of clinical supervision in place. So I think one of the things coming out of that meeting that we were kind of looking at is, okay, Medicaid billing could be a piece of the puzzle, but we maybe need to look at supplementing that with other kinds of funding or thinking outside the box in terms of how to fund these services. Does that about sum it up?
Yeah, it does. Thank you, Meta. That was great.
Yeah.
Also too, one thing that got us all kind of thinking, we had a meeting after the meeting. What kind of made us, what made us kind of think about this is that the process, and so this is where I really want some info from everybody here is that if I'm a patient and I'm in Seattle and I need an assessment and I call up wherever just to get a phone number and I keep on trying to figure it out and I just don't know where to call, and then that's part of the process, right? It jams up, patients get jammed up on where to go. And then let's say finally I figure out where to go, and then like is the peers being at all the agencies, is that's what's needed? Or is a central location where a person can call and then receive peer services from that central location, could that possibly be something that could be explored? So something that was talked about was and just a quick show of hands. You can just raise your hand. Anybody here ever heard of the Washington Recovery Helpline? Or thumbs up? Okay, good. So a couple people. That's good. Okay, good. Glad to hear that. So one thing that got brought up, and I thought I'd just give you guys the information, and you guys tell me what we're going to do next. Thank you for the show of hands, appreciate that. But the Washington Recovery Helpline has this thing called the Mound Finder, and it was done with a special grant. And 2 miles, I can click on methadone clinic, I can click search, and yeah, I can put it in Tacoma, have it search, and then it puts in all this really cool information, and it gives me all this stuff. It has all these check boxes. It's really cool, right? And it provides a really great resource for people to be able to find their stuff. And this phone number is 24/7, right? There's a 24/7, 7 days a week phone line. Right now, when you click on outpatient treatment, some of you will recognize this. This is the Green Book, and it's just listed in documentation. And due to funding, that this doesn't have the same functionality as the Finder. And just so everybody knows, the Green Book. Maybe there's someone on the call that doesn't know, but the Green Book. The reason why it's called the Green Book is because it used to get printed out once a year, and it used to be sent to the agencies, and it was green. And so it lists every agency in Washington State and what services they provide. For instance, this one right here, and it has who's the administrator, the county mental health service, and everything like that. But you notice that it's really hard kind of to read and stuff. The Green Book is really for provider consumption, not really patient consumption. So I just wanted to bring this website up as a possibility, so you guys would know about. I mean, great, everybody knows about this resource now if you didn't know, but yeah, this, if more funding went this way, there could be a possibility where peers might be able to be added to it, and they can track the person until they get the actual assessment, and they can be like, hey, like, let me help you, and it could be a way to grant fund something. So it's just an idea, and I thought I'd present it to all of you. Anybody has any, like, I can't really move forward until someone from the work group says I like that idea, or something, Kelly, no, I think this whole thing recommendation should stay as it is. I want to bill Medicaid at my agency so we can have a peer here, and we should do it with individual agencies, or we got to have some type of discussion on it before I can put anything about Washington Recovery Helpline. Yes, Dominique.
Does this allow for like agency kind of independence? So agencies can assess how many peers they need versus.
That would be more of it, because the place isn't ran by peers right now. They don't have peers as far as I know. Crisis Connection runs it, and so that would be a later question on could that be a possibility. So I don't know, but I could research that and find out. I'm gonna move on to. I got one other hand up. Kara.
Hi. Yeah, I'm not unopposed to adding that. I think with this recommendation, I mean, I think we could endlessly kind of get into the weeds on different tracks to go on this. And I mean, just also acknowledging though that we're not trying to solve, we're making a recommendation rather than a direct maybe solution to something. I don't sorry, I don't have um a direct yes or no on this. I don't know. I have concern that, you know, we might kind of start getting into the yeah, if we can maybe research a little bit more what the what that resource would look like um as the recommendation. Yeah, sorry, just my disorganized answer there. I just think a little more work on that might be good. Thanks.
So, Car, just to make sure I got it. So, basically, more information on what it would look like if there was a central location of peers that would assess
Yeah,
individuals to go
yes.
from the street to all the way to getting their assessment.
Yes, I think this recommendation could get very broad and can go in a lot of different directions. I think we can nail down the direction we want to go. That would be good.
Okay. Susan?
Yeah, hi. I have a question, and I probably should know this, but if this were to go through, would peers be able to bill Medicaid not being affiliated with an agency, just as an independent provider?
No, I don't believe so. I wish I had somebody else here from MPD, but as far as I know, with if this went through, then if they were underneath, if a peer was underneath an agency, they would be able to bill Medicaid if they were underneath an agency. And then, did I answer that? Does that answer your question?
Yeah,
Or
yeah. So the
okay,
agency is actually who's billing the Medicaid, not the actual peer.
I mean, it's the agency who does it with the peer's credential, and so I mean, that's where this comes in. It would make it so that peers can bill Medicaid with the agency that they're a part of.
Okay, thanks.
Yep. Alicia?
You may have already answered this, so I apologize if you have.
No.
Having a central location for peers, how would, I mean, are you saying that they couldn't open and like another agency couldn't have peers? Would it be specific to a certain location? And then my other concern would be, I live in Yakima, and so, we don't have the population that Seattle does, but we still have quite a population. Is it going to be limited to based on population specifics? That would be my concern.
Yeah, when I was looking into this, great question. So when I was looking into this, the whole reason why central location kind of came up was because, like, let's say if you went through grant funding for peers instead of Medicaid billing, it's like, so for instance, you're in Yakima and then you have Seattle. So what Yakima needs and what Seattle needs is like two different needs, and then the amount of people, determined by that. So, um, I mean, I think that someone put in I don't know, it was, um, Charnay put in, what about both? Which I think, is it possible? I mean, that basically turns it into two different recommendations. I feel like that'd be a pretty robust recommendation to say, let's make peers Medicaid, but it's something I'm willing to research and find out if it's doable, if we could do both after this meeting. And so, Alicia, I hope I answered your question.
You did. I was just something
Okay.
that I was thinking about is the concern is if we have a central location, does that limit for other people and then the different population based on across the state? So it really just is more of a concern versus a need to answer today, Kelly.
Okay. Understood. Thank you so much. I have it in my list of stuff. You guys are giving me good research. Cara?
Yeah, and just to add, I totally agree, Alicia, and also, you know, coming from an area here in northeastern Washington. We have a lot of our frontier rural communities really are challenged with workforce and having enough people to hire in when we expand and create any new program. I mean, it just creates more pressure for our rural communities to staff those resources. So I lean more toward, are there ways that we can enhance existing programs that can do some of this work? But that's also, my opinion on that. But I just echo a lot of what Alicia was saying. Thanks.
All right, Meta.
Yeah, I just want to go back to Kara's original point or previous point about, kind of what level we're at here in terms of getting into the weeds. I think we can maybe further down the line discuss central location or decentralized services, but this recommendation is really supposed to be more about how to fund it. Right? So if we were focusing on having peer services be Medicaid billable prior to a full assessment, that could be something that could be implemented in a central way or in a decentralized way. But it doesn't really depend on the model. Does that make sense?
No, it does, Meta. Thank you so much. I put it in there a question mark about funding. If there's and if any of you on here have a way of in which you think funding can be done other than through Medicaid, I know grants, yeah, that's always possible. But I'm willing to list them here if I need to research some ways to fund them. I could still research the cannabis tax and see if that's a possibility for funding.
Well, and there are like telehealth providers, I believe that employ peers. So not necessarily a centralized location, but still, and I don't know if it works as in those providers get licensed as a behavioral health agency and then they're able to bill Medicaid for those peer services. But if we're talking about, the need to be attached to an agency to bill and what that means for being able to kind of deploy peers statewide, especially in areas without a lot of like brick and mortar facilities, just could be something to consider.
Thank you, Sarah. Okay, so does everybody want me to do more research on this following stuff and funding and then send out an email and get back to the group on this? Let me get like a thumbs up on that. The recommendations are coming up, so I'm gonna have to do a lot of research like right now, like right after this meeting. But I'm gonna get it done. I'm gonna do my research right after this meeting, and I'm gonna get back to you guys. And so if everybody can be responsible, try to be responsive if you can through your email because we don't meet again until the 28th. So I might need quick responses from everybody just so everybody knows. And I'm gonna go ahead and mark yours here, Sarah, for me. I'm gonna mark that down. There so that I can research about that as well. All right, is there any more that somebody would like to add to this recommendation or if so, please raise your hand or also too, I think I put make sure it's in there. There we go. The recommendation is in there. I am going to turn on track changes. I see no raise of hands. All right, Meta, I am tracking yours now. That's not how track changed. Thank you, Meta. Appreciate it. I went ahead and added it to the document so we could look at that more too as well. All right. the fourth recommendation. I think more people had to say on this than anything, so which is really cool. So expanding remote access pathways to receiving SUD assessments, i.e., via phone or video call, and increasing virtual treatment options. So I just want to start off with this, the first one, because I think everybody was kind of really interested in this. Phone assessments. So basically, it was said that where's my yellow sticky notepad? Right here. I'm gonna put this in the chats. I'm gonna put this in the chat real quick. This is the RCW that deals with telehealth. So you can all read it and all that stuff. So basically, right now, how it's written is telemedicine means the delivery of healthcare services provided through the use of interactive audio and video technology, permitting real-time communication between the patient, the originating site, and the provider for the purpose of diagnosis. So I met with the DOH, and they basically told me that uh, we can put what we want in a recommendation, but DOH basically told me that it would be a real hard ask for the legislature probably to approve phone assessments at this time. However, it did tell me that rulemaking on BHAs, behavioral health agencies, is going to be happening in 2025, and that we could become, we can make sure to track this of when the rulemaking starts, and I could, you know, we could send out information to a lot of agencies who feel really passionate about phone assessments and why it would be so important. I'm not sitting there saying if we put in a recommendation that this can't get changed because I'm not like a lawmaker or anything. I'm just saying that when I spoke to the DOH, it didn't seem like something that was going to be feasible if we did recommend. But we can still recommend, like I said. I just that's what I got told from DOH from that. And so I think that there's other ways that we can provide assistance to facilities. There's a whole bunch of ideas right here that was done in the breakout rooms. The recommendation can make it so that HCA helps support treatment agencies to update P&P policies and procedures. HCA to provide education on the difference between audio only and telemedicine based. Offer HCA support on what is allowed versus not allowable. Also, too, there might be an agency out there that's doing this telehealth thing like 1,000 times better, and it's not proprietary. And the HCA might know about it, and we might be able to share that with other agencies. The process more than documentation or uh, the video app or anything like that. Just the process in which someone does video chat. And so HCA to create and publish a list of SU agencies, consultation services who can perform SUD assessments. Right now, the Green Book does not have whether or not someone does telehealth because it's not a listed service. Like level 1.0 outpatient is a listed service. So right now, it doesn't say whether or not you'd have to find telehealth agencies by Googling them and finding, as far as I know, that's the way I would have to find them. I'd have to click on the facility and I have to see if they offer telehealth as an option. And so that's something we could do. We could help make a mass list of telehealth agencies, and it could be interactive. That's one possibility. That's where we're at with this. Is there something more that we should add to this recommendation right now? Oh, I did find this out. Updating the Green Book, DOH did tell me that was a no. They said for updating it as far as telehealth services, they said that's not a service, so they won't. I can delete that. They won't do that because it's not a service, so it doesn't go in the Green Book. I'm gonna put the link for this in here. All right. So kind of waited a little bit, and I haven't had anybody say anything about recommendation four. Could I see some thumbs up that we're good on this, or that somebody will work on this while in the next coming days? I'm going to start tracking changes now again for everyone. And so that will happen. You can comment or track changes. I put the link in the chat. So as far as any of the recommendations, is there anybody else that wants me to go back to a recommendation to have further discussion about it? Does anybody from the steering committee have anything to say?
Sorry about
Okay.
your crickets, Kelly. I'm tempted to come up with something to say just to break the silence.
I got two more people to go on my list, and then we move on to the next part of the agenda, which is pretty much discussing closing out. But Michelle, did you have anything to add to what we discussed today for recommendations?
Not to the recommendation specifically, but I just want to say thank you so much to everyone who got into the recommendations in between the meetings and read them and provided input and like kept this moving in between the meetings. It's so helpful. So yeah, just big thank you to everyone who did that, and to those who have contributed during the meetings as well. Of course, we really appreciate it.
Yeah, I'd like to reiterate what Michelle is saying. Thank you so much, everybody. We do appreciate you guys. I know that I mean, I just got done doing direct services for 12 years, and I know that everybody's day is packed, jam tight. And getting here into the Word document, trying to figure out how to best help the next patient and everything like that is like, we're already helping a patient. They're in front of us. So you guys getting into this document and really working hard on it, I see a lot of good work here. So I'm appreciative as well. Thank you so much. Brianna, was there anything that you wanted to add?
Nope.
Okay. All right. Well, the next part of the agenda is next meeting is August 28th. And I'm hoping to have input from the associations and SURSAC by the 23rd. I got quite a few meetings this week and quite a few emails I'm waiting on to hear more recommendations. And so on the 28th, we should be discussing like what the associations might say for recommendations. They might give us a lot of information. They might not. It's really up to them when they meet and how they want to discuss the recommendations. But before we change anything or the heart of what we're doing here, would definitely meet with SUDISA before we do that, so you guys know about it. So, all right. I guess I will go ahead and give back people about 25 minutes of your day if there's nothing else further to discuss. All right. I'm going to go ahead and call the meeting then. That'll be it. Thank you, everybody, for participating. Appreciate each one of you.
Thank you.
Thanks, Kelly.
Thank you.